All right, it's recording now. But yeah, so now now that you guys have learned more things, looking back, you should be able to contextualize the diseases and specifically like the Mass Effect problems that you have here. You have things like your uncle herniations, which push on the cranial nerves. You have the third nerve palsy that you get with anterior carotid aneurysm problems. Um, yeah. Neural tube defects, generally, if they ask you a question about embryology, this is what they're going to be asking about. Super duper, unbelievably high yield that folic acid deficiency is responsible for a large number of the neural tube defects. Alpha fetoprotein should not be in general circulation in the embryonic fluid. If you detect alpha fetoprotein, it means there's an opening in the spinal cord somewhere. Well, not the spinal cord, but there's a direct confluence between the area immediately surrounding the spinal cord or the CSF and the external environment, right? Um, Generally, when they ask these questions, they're going to be asking you to differentiate between one of these. Sometimes it'll be a really big step, or it'll talk about like the mother like not taking prenatal vitamins, and I'll say something about a small tuft of hair, to which point you should automatically know that it's spina bifida occulta. But a lot of times, they'll talk about how either they'll name one of these and they'll ask you to know like whether the arch failed to form, um, whether or not the subarachnoid has like escaped the spinal column, um, or they will do it in the other direction. Well, they'll describe this, and then you'll have to give a name. So please know the name of this. And the way that I always remember this is meningeocele is like is it starting to escape, right? The meninges are starting to like push out. And then the myelin meningocele is like more, right? Like it's you're adding onto it. I've definitely seen questions where they just straight ask you if it's a rostral or caudal cranial tube defect, right? So you'll end up if it's caudal, you end up with spina bifida. If it's anterior, you end up with encephaly. One of the ways that they can also ask this is now that you have done all of the farm, right? If a mom is taking, oh boy, don't want to mess this up. Phenytoin, right? It can cause cranial nerve defects or neural tube defects, and it causes anterior defects, right? It causes encephaly, and then like lithium causes like the Epstein anomaly. So knowing that encephaly is a interior neural core failure to close, is a lot of times how they can like work that throw you off. So be aware that even if that the answer can be spina bifida, but the physical answer that you're going to select will be failure of the posterior neural pore to close, and then the same thing with encephaly. The answer can be failure of the anterior neural pore to close. That they just like to word it like that sometimes on NDME. Meningeal layers. I think we have this down, right? But the top's the dirt, it's the tough part. The arachnoid is where all the fun stuff happens, and then the P is the bottom. This helps you with the bleeds, right? You have your epidural, subdural, right? Epidural is above, it's between the skull and the dura. Subdural is below, right? And then you have the arachnoid bleeds. The only reason why I know you guys know what this is, but sometimes the questions they'll be asking, it will be like the answer will be superficial to the dura. Like they'll be asking about epidural hematoma, but they'll be asking like where the blood is collecting. I know a lot of times we like run through this stuff and you don't think about the actual like breakdown of the words. They like to word this strangely. Is basically what I'm saying. The other thing, when you get the epidural hematomas, please do not forget that this is responsible in most of your questions. In most questions that are asking about something like subfalcine herniations or uncle herniations, it will be because of an epidural hematoma. Technically, yes, tumors it can cause mass effect. Mass effect is responsible for most of the weird things that happen in the brain like this. But it is usually an epidural hematoma that leads to these things in question 7. You super duper cannot stress enough need to know all these buzzwords. When you see one of these questions, you should roll your eyes because you're asking why are they giving us these stupid simple questions, right? Lucid interval, epidural hematoma. Bridging veins, subdural hematoma. Thunderclap headache, subarachnoid, right? Know what causes them. Epidurals are usually for fractures, like this is usually trauma. Subdurals are usually in older people. Why? Because the gray matter shrinks, it pulls the brain away from the dura. The bridging veins end up with tension on them, and when we get coup counter coup, any type of whiplash, adjacent injuries, they tear those bridging veins. Gradual confusion, right? Thunderclap headaches, either this will be stupid obvious in the stem, or they would talk about some disease that gives them a predisposition to AVMs, like HHT, or it's also called Oslo-Weber-Wendow syndrome, right? You're very aware of these, but usually it's going to be super obvious which one of these are, and they're going to ask you where the damage is. Just straight up. That is usually the answer you're choosing. Will be middle meningeal bridging veins, or ruptured aneurysms, right? Uh, I don't think I've ever seen a question on these without a picture to go with it. So don't see this and immediately think tumor. Be aware that intraparenchymal hemorrhage is a choice. If they do ask you a question and it is not a picture associated with it, or even if there's a picture associated with it, you need to associate intraparenchymal hemorrhages with Charcot-Bouchard aneurysms, right? Which are the little ones in the lenticular striate vessels usually. These will cause internal capsule strokes, which now you guys will know is purely motor, right? So if you see somebody who has hemiparesis of motor, or they have hemiparesis of body with contralateral paresis of face, you should be thinking internal capsule. No sensory deficits. Intraventricular hemorrhage, super unlikely they're going to ask you a question about this. Usually it's in premature kids. If they do ask you a question about this, it will be a really weird question, and you'll just have to have like some general understanding of the anatomy, the way that the CSF flows. Something that they kind of ask, I guess, is they will tell you that there's an intraventricular hemorrhage, and what you need to be thinking about is that now they have a risk for this blood to clog the subgranulation tissue and prevent the reabsorption of cerebrospinal fluid. That's a usually if they're asking about this, that is the kind of pathophysiology that they're looking to see if you know. Denny Walker malformations. Every time I've gotten a question about this, I've seen this picture and stopped reading the question and pick this as an answer. No, 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 no. Be aware of that it can cause non-commuting hydrocephalus, right? But this is the other big thing here is that it's failure of the cerebellar vermistiform, which is the middle, right? So you can think this is, obviously, if you don't have a cerebellar vermis, that's responsible for like your truncal sensation, right? Cause truncal ataxia. Yeah, but usually you get a picture with this. Please don't miss these questions. The picture should make it stupid obvious. Don't think it looks even remotely like this. Hydrocephalus, communicating just means that the cerebral spinal fluid is moving. So that means it's either being absorbed slowly or it's being produced in excess. NPH is a type of communicating hydrocephalus. Please do not forget that. I've definitely seen questions where the person clearly has NPH and the answer is communicating hydrocephalus, and you kind of like think about it, you're like, well, that's a really weird way for them to want me to answer this, but technically it is correct, right? This is your wet, wacky, and wobbly. You should not miss any of these questions. I wouldn't be surprised if you had literally just 2 questions that just wants you to know if it's NPH on the exam, to be completely honest with you. The other thing is I have actually seen questions, and a lot of people don't realize this, but what causes the actual problem is it's not mass effect in the sense of where it's not like that because the cortex is being compressed. It's actually because you get dilation of the ventricles. It's stretching the fibers as they go around the ventricles, and it's the stretching of the fibers that causes the symptoms here. Non-communicating, this is super obvious. It's just an obstruction. Usually it'll be like a pinealoma or something like that. But yeah, it's usually like I said, it's either the cerebral aqueduct or the foramen Monroe that's blocked here. It's usually the cerebral aqueduct. And then hydrocephalus ex-vacuole, right? There's just fluids filling the space where the brain shrunk away. This is more relevant to you now that you're closer to CLR, but just please don't forget these things. Lumbar puncture at L3, L4, even with iliac crest. Between NBME exams, comp, the forms, and step 1, I think I've put this as an answer 10 times. Please do not forget anything in this bullet point. Please do not forget anything in this bullet point. This is a throwback to MSK, comes up all the time. Know these landmarks. You're not going to get asked a question directly where they ask you to identify the T4 or T10. However, they will ask you a question where this is knowledge that you need to have as background knowledge to answer properly, especially in something like Brown-Séquard syndrome. Thoracic spinal cord has lateral horns. This is super important. Do not forget this, please. The bottom of the spinal cord has larger anterior horns because there are more motor neurons because they have to project down through the legs. This is why I believe that polio affects the lower spine more than the upper spine, because the polio virus really likes to live in these neurons. Um, Also, we'll get to it later, but please don't forget that when you're talking about upper and lower motor neuron injuries, if it's anything before the anterior horn, it is an upper motor neuron injury. If you're talking about the body, right? If it's anything above the cranial nerve nuclei, it's a upper motor nerve injury for the cranial nerves. If it is the cranial nerve itself, or it is one of the nerves that has a cell body in the anterior horn and then projects down, it's a lower motor neuron injury. Technically, if there was a lesion in the anterior horn itself, you could have either upper or lower motor neuron injuries depending on where the disruption was. But I've never seen them ask a question like that because it's just really underhanded. If they're asking you or telling you that there's damage to the anterior horn, or they're asking where the damage is in a lower motor neuron injury, generally, classically, for sake of testing, anterior horn injuries are lower motor neuron injuries. Know this. I can almost guarantee, I would almost bet a beer that you're going to get a question on this. Be able to distinguish muscle strength, like literally just straight up. They would just straight up ask, is this a 3? Is this a 4? Or they would tell you that it has been graded as a 4. An attending or a resident tells you that the person has muscle strength of 4. Which of these will they be able to do? The big thing they usually want you to distinguish between is can they move the body part against gravity? So you're 2 or 3. Please know this. Spinal cord organization. If you know this, you should never get a lesion or a track question wrong. Guarantee you will have questions on these. If I had to guess, 5 to 7 questions answering where you need to know this, essentially. Please do not forget that the graciculus is the lower body and it is in the middle. Graciculus, G for ground. And the cuneatus is the upper body. It's just not the ground, right? That's how I remember it at least. Remember that this is the middle of this is your sacrum and it ascends up the body, and then it's opposite for everything else, basically. Please, please, please be able to point to the descending and ascending tracks. If you got this picture with no labels, I've definitely seen questions with this picture with all the words taken out, and you've had to, they would describe loss of pain and temperature, right? And it's not enough for, they'll be like, all right, it's the right leg, right? Loss of pain and temperature. And you know that that means it's going to be, it crosses immediately, right? So you know that it's going to be the left lateral spinal thalamic tract. However, you need to know that this is the left lateral spinal thalamic tract, right? You need to know that this is the cortical spinal tract. And I have definitely seen questions where they will have 2 arrows here. And basically, you need to know that like this is the sacrum and this is the neck, right? So like you would need to know that like this is the arms and this is the legs. I know it seems really cruel, but they definitely do ask questions like that. They definitely do ask questions like that. Spinal cord syndromes, you should be able to draw this. If I asked you right now to draw this from memory, you should be able to get this diagram about 70% correct at least, please. If you can't find a picture of a dude with no drawing on it at all, just like a little silhouette or something, and start coloring it in the spinal cord and the person themselves. Make yourself a nice resource, use it for CLR studying. But this is really important. You super need to know this. You'll definitely get questions on this. You should never, ever miss a central cord lesion syringomyelia question. It is so obvious in all the stems. It is the only time they're ever going to be talking about bilateral pain and temperature loss on the arms. You have that cape-like distribution. The only thing to remember is that as this lesion gets worse, it can start to impinge upon the other tracks that are there, right? So if we go back to this picture, as this grows, you'll lose your motor function, and then you'll start to lose, but you lose it in order of like you lose the cervical first, so it's like you lose motor up here, and then it goes downwards, right? Brown-Séquard syndrome. These questions will be really obvious. They like to make a deal about the whole pain and temperature is like 3 up, right? However, it's so obvious when it's Brown-Séquard syndrome, you shouldn't miss these. Please remember for anterior and posterior cord syndromes, remember the difference between hyperflexion and hyperextension. Generally, you're like closing on the one that's damaged. So for anterior cord syndrome, you're hyperflexing, and for posterior cord syndrome, you're hyperextending. This can also be trauma. You can also get occlusion of the either anterior or spinal arteries, right, that supply the spinal cord. Please don't forget that there's a dual blood supply here. So with posterior cord syndrome, sometimes it'll be unilateral, whereas there's only one blood supply interiorly. So you lose the entire anterior cord when that is occluded. I've definitely seen questions that on forums read like they're, I don't know, like clotting questions or cardiology questions or weird questions like that. But it's actually something is throwing emboli, which are occluding these vessels, and then it's like anterior cord syndrome or something. I don't know. Yeah. We just talked about this. I sincerely hope that by now we know that posterior cord is responsible for proprioception and vibration. Anterior cord is responsible for everything else. Swinger myelin is associated with the KRA1. That might be relevant. I would know that. Like I said, Brown cord. You guys all know what this does. I don't need to hammer it home. It's really obvious in question stems when you have those mixed symbols. The only other time that you're going to have like a weird one half of their body is doing this and the other half of their body is doing this is in polio in questions, in polio or ALS. Those are like, if they're talking about things happening on both sides of the body and it's not like a delineation between motor and like in the cranial nerves, you can almost guarantee the question is asking you either about Brown-Séquard or polio or ALS. And the really easy thing is like polio, right? You just like lose motor function of the lower limbs, right? ALS, you have mixed upper motor neuron signs just scattered all about, right? Oh, the other thing, did we talk about this? I don't know. I don't remember talking to you guys about this, but maybe. So I'm just gonna say it now before I forget again. Lambert-Eaton versus myasthenia gravis is stupidly high yield. Myasthenia gravis is antibodies against the postsynaptic acetylcholinergic channels, right? Lambert-Eaton is antibodies against the presynaptic calcium channels, right? Super, super, super high yield. The other thing too that I'm just going to mention before I forget, Guillain-Barré is ascending paralysis, right? It can be triggered by any type of viral infection. It's triggered a lot by abdominal infections in kids, according to board questions, and it can be triggered by any vaccination. Guillain-Barré is ascending paralysis, which will distinguish it from the other neurological disorders. If you see ascending paralysis, I think Campylobacter. Don't quote me on this. I think Campylobacter has a big risk for Guillain-Barré. Pretty sure it's Campylobacter. Maybe look that up. Tabes dorsalis is syphilis, right? You lose the dorsal columns, right? So you'll have a positive Romberg sign. Remember, Romberg sign is you close your eyes and you lose your balance because you don't have any proprioception. Whereas the vestibulo-ocular kind of reflex causes like the nystagmus, right? Because like you don't have a sense of balance in your ears for motion. No, for sure that Romberg sign is due to proprioception. So you get it in tertiary syphilis, right? Tabes dorsalis. And the B12 deficiency. Please be aware that on tests they like to call B12 deficiency subacute combined degeneration. And again, you'll also get these are your two like big positive Romberg signs. This is super duper important. Know that if you have decorticate or cortex is above the cerebellum. If you have decorticate rigidity, it means that the lesion is above the red nucleus. If you have decerebrate rigidity, so their arms are down at their sides, pointing towards the ground, you have damage below the red nucleus. Almost guarantee you'll have a question about this. Remember that progressing from decorticate to decerebrate is bad. Progressing from decerebrate to decorticate is good. Please know this. If it hasn't been said 46,000 times, I'll say it for the 46,001st. Please know the circle of Willis. Please know the circle of Willis. and know the blood supply regions, right? You guys should know this by now, especially with the strokes, right? MCA is anything on the sides, a lot of your aphasia. ACA is almost always going to be a lower limb stroke, right? And then PCA is posteriorly. And then anything else, ICA, PICA, ASA, but basilar arteries, those are all of your brainstem injuries. Yeah. So your anterior spinal, right, or anterior cerebral, sorry, provides blood to this chunk, right? So it's usually the lower limbs. MCA, if there's an aphasia, MCA is a pretty safe bet. Also, if there's limbs. And then PCA is you'll have that occipital lobe, right? So that's when you can get like the macular sparing, their bilateral hemianopsia with macular sparing, right? So PCA. And then ICA, they don't really ask too many questions about like ICA occlusions because like how are you going to occlude the internal carotid? It'll usually be an aneurysm. It'll usually be causing third nerve palsy or something like that. Or or like some type of active nerve involvement. Brainstem strokes. I beat this to absolute death with y'all with the rules of 4. This is obviously very high yield. You're 100% going to have questions on this. You're going to have probably a question asking you, if I had to bet, I would say you'll have a question asking you to localize where in the brainstem the stroke is. You're going to have a question asking you to localize probably 2 of those. Maybe the other one's like a tumor or something, or they'll just say like a general lesion. Then you're going to have one that's asking you basically the same exact question, but instead of asking you which part of the brain it's in, it's going to ask you the blood supply. Honestly, probably of those types of questions, I would expect 3 to 4 to 5 of them. There's a lot. They like to ask these a lot. All of the sensory stuff is laterally. It's on the sides, right? So like your tag, spinocerebellar, spinothalamic, right? This is all the sides, and then the middle is mostly motor, right? Please be able to draw that diagram I showed you guys in the past. This one, please be able to draw this. Please be able to draw this. If you can draw this, you shouldn't miss any of this question. Yeah. Also, don't forget these. For whatever reason, they really like the fact that 1 and 2 are myelinated by oligodendrocytes because they form differently than the rest of the cranial nerves. And 3 through 12 are myelinated by Schwann cells. Just real quick aside, please don't forget that 1 oligodendrocyte myelinates a bunch of neurons, whereas in overwhelmingly most cases, and according to all the things that you're going to see, Schwann cells, it's 1 Schwann cell for 1 neuron. Well, it's a bunch of like 1 Schwann cell wraps around a single neuron, whereas the oligodendrocyte reaches out and wraps around a bunch of different neurons, right? You can have more than 1 Schwann cell innervating. You do have more than 1 Schwann cell innervating a single, or not innervating, but insulating a single neuron. But just remember that multiplicity. I've definitely seen questions with that. Watershed strokes and lacuna strokes. This is where the blood vessels almost meet, right? It's just like in the gut with like you have like the splenic flexure, right? Or like the right after the sigmoid colon, right? Water, same deal. Any type of volume loss. And then lacunar strokes, these are your small vessel strokes, right? These are usually in the basal ganglia. You have your strokes here, or you have your internal capsule stroke where it's just purely motor. You should definitely know what the cranial nerves do by now. I don't really have anything else to say about that. You need to know what the cranial nerves do by now. I would remember that generally any damage to cranial nerve 1 will come about as some type of fracture. If you have anosmia, there's one inheritable genetic disease that leads to brain tumors that like the hallmark giveaway is anosmia. I'm gonna be honest, I don't remember what it is. Would I process of elimination my way to it in an answer choice? I think so. Maybe look this up. I hate to say that, but I just don't remember what it is. There's one inheritable disease that leads you as a predisposition to tumors that causes anosmia. But outside of the context of that, overwhelmingly, if the patient has anosmia, either their ethmoid bone is fractured or their cribriform plate is fractured. If the cribriform plate is fractured, it shears the olfactory neurons, right? You guys know down and out, cranial nerve palsy, right? Know which way the tongue and the jaw and everything moves when you get cranial palsies of like 5 and 12, and the uvula deviation, right? The tongue deviates towards the side that's there's a lesion. The uvula deviates away from the side that's a lesion. Um, the jaw also tilts towards the side of the region. Um, Definitely know this. Know the cornea reflex. Afferent is 5. I'm almost positive that efferent is 7. Yeah, it is right here. Yep. So with the tear reflex and the cornea reflex, 5 is your afferent and 7 is your efferent. Um, I feel like this was historically tested on a lot, and because of that, they've now started asking this. Um, the jaw jerk reflex is both the afferent and the efferent are both the trigeminal. That's just a little. Just please keep that in the back of your head. Abducens nerve, we beat this to death with vision. Also 5 and 7. Again, this is another thing. They always ask about 7. I've definitely seen questions about 5, and I think it's because of this. They both innervate muscles that tense up when we're exposed to loud noises and reduce like the impact of sound. So you become sensitive to sound if you have a 7th nerve palsy. It is also possible with a 5th nerve palsy, but 7 is the more common one. I don't remember the names of muscles. When you see them, you'll kind of remember. You'll be like, "Oh, this is the thing. This is what's going on." Hearing balance. Yep, this is the vestibular nerve. That makes sense, right? Know this for sure. Right. 9 carries the carotid sinus receptors. 10 carries the aortic arch receptors. Uvula deviates away from the lesion. This is your accessory nerve, right? So this innervates the trapezius muscle. I've definitely seen questions where they ask about this. And then, of course, this is your general like tongue deviation question for the hypoglossal nerve. We all know what first order neurons are. This shouldn't be that important, but you're going to get at least one question on it. Be familiar with these. That's really all I can say. I would say for this, generally know what they do. You probably don't need to know what type of fibers each of these communicates with, but I would 100% know, like physically what they detect, right? Like Meissner corpuscles are vibration, right? Basinian corpuscles, they have your high frequency vibration, but I'm pretty sure they're mostly pressure. Work with this, yeah. Know what these do. This you need to know. Know the order that this goes in. Right, you have your 1A and 2 are your big muscle spindles, and then most of your sensory cells are the betas, right? The A betas, and then you have your deltas, which are like just the free nerve endings, and then you have the unmyelinated ones. The reason why this is important is because quick, slow. So you can then deduce that these are going to be responsible for like your like reflexive, like oh that's hot, oh that's sharp pain, and then these are going to be more like your nagging pain, right? Also, important thing to note, I've definitely seen a question on this. It seems counterintuitive to me, but the wider the diameter of the axon, this is why it's faster. It's faster because the diameter is big. I guess it's not really counterintuitive to me. You have the surface area to volume ratio is lower, which is basically like you're insulating it with nylon. So I guess it makes sense why they'd be faster. But I always mix this up in my head. I guess the way to think about this is the fastest axons in the entire animal kingdom belong to the giant squid, and they're about this big around. But yeah, bigger diameter equals faster conduction velocity. Weber and Ryan test, 100% know how to know this. 100,000% know this. I think we had 3 questions on it in our final. Be able to answer this in every direction. Be able to answer this both if they give you, oh, well, there's air conduction is better than bone. And it's like localizing, that it's sensorial. Know that if they tell you that the person has conductive hearing loss, that bone will be better than air, right? Know this. Know this, know this, know this. If you don't know this, if there is even a 1% chance, there's even a 1% chance that you don't think you'll answer this correctly, even if like if you don't think you can answer at least 9 out of 10 of these questions correctly, please take the 5 to 10 minutes after this. There are a billion YouTube videos that like explain it so well. So well. Um, yeah. Yeah. This is really important. I guess just real quick, like air conduction should be better than bone conduction, and it should not localize to either ear. If air conduction is not better than bone conduction, then you have a conductive hearing loss. Conductive hearing loss means that the sound is not making it to the sensory neural cells in your inner ear. If the sound, so therefore, when you use bone conduction and you bypass that part of the ear, it will be able to transmit the signal better. If you have hearing loss, but air is still better than bone, then you know that the hearing loss has to take place after the sound has been conducted to the sensory cells, therefore to sensory neural. Please know this. I'm pretty sure that you're going to have a question that will specifically ask you which ear this is going to localize to. I almost guarantee you'll have at least one question like that. This is very important. Yeah. Right. This is what we just talked about. Oh, this is something I always get confused too. Positive is good. Positive means that everything is as it's supposed to be. Negative means that there is hearing loss. Um, you don't need to remember like all the pathways and nuclei here, but do remember that you have dual innervation. Like the pathways go both sides of the brain, which is why it's very hard to get a lesion that leads to deafness in one ear. Usually, you just end up with some type of hearing loss. If you have a lesion that leads to deafness in one ear, it has to be in this spiral ganglion neuron, like right the primary neuron. So if you see a question and they tell you that the patient has some type of neurological deficit that is causing complete deafness in one ear, you know that this neuron has to be damaged. Specifically, this neuron and only this neuron is damaged, right? Yep, that's it. Know that higher frequencies are early and low frequencies are late. In the cochlea, this is why we lose higher frequencies due to damage first. I talked about this earlier. Know that you need to be able to smell the taste. Remember that 7 provides the front and the back is provided by 9. Epiglottis, we taste with our epiglottis apparently. It's a stupid fact they might ask about. It's 10. These are all of Dr. Colello's little diseases. We talked about all these. Smooth brain, wrinkly brain. Brain isn't divided. We talked about Benny Walker. Talked about these. The pneumocephali. Air in the head. This happens due to trauma. The only time I've ever seen a question on tension pneumocephalus is you get that Mount Fuji sign, right? Which is where the front of the brain looks kind of like this, right? Super obvious. MS. Every question about MS is really obvious. It's MS. Please remember that it's destruction of the oligodendrocytes. It's an immune-mediated condition, which is why it waxes and wanes. You get those little like fingers coming off of the ventricles. I forget what they're called. I'm sorry. I'm really bad with names. Herniations we talked about. All the hydrocephalus. Everyone knows what these are. Autonomic dysreflexia. If you lose sensation below, it's really like your diaphragm. What will happen sometimes is your bladder will be full. Your body will know your bladder's full. Your body will be upset about it, but you won't be consciously aware of it. That's when you get like the splitting of where you'll have like cold and clammy on one, like the top half, and hot and sweaty on the bottom half, or vice versa. I don't remember which one it is. It's the only condition that does anything like this. Be aware that it exists. You have your spinal cord syndromes. Beat this to death. Strokes, we beat this to death. All the lesions. Referred pain. Referred pain questions are weird. We know referred pain is like your shoulder hurts when you have a heart attack because the nerve that innervates the capsule is the same nerve bundle that innervates like pain in the shoulder, right? Be aware of that. These two are kind of together. Yeah. Proboscis is just hearing loss of old age. We talked about these. Okay. I'm going to skip all these practice questions in the first one in interest of time when you guys have seen these before. Also, it's not super useful to go through and just, I'd basically just be regurgitating the step book at you guys to talk about these disorders. I will talk about the farm. I highly recommend that if you are still hazy on these, the best way to learn these is to do your rule questions. I'm sorry. Even if you're not doing them, but like reading them, like just go back through your incorrects and just read them. Because they want very specific phrasing for a lot of these answers. And it is, they word it one specific way, and you're supposed to think of one specific disease. And NBME tends to word it the exact same way. I thought that there was a lot of similarities between NBME and your questions. The one thing that I will talk about real quickly, PTSD, there has to be a traumatic experience. If the experience is not traumatic, it is not PTSD. Panic disorder, you are anxious about having a panic attack. The anxiety stems from the fear that you are going to have another panic attack in public. Generalized anxiety, they'll usually have a bunch of different, they'll be anxious about a bunch of things, not just one thing. Adjustment disorder is almost never the answer. I don't think you don't see questions on phobias very often. Delusional and brief psychotic, this can be kind of hard to distinguish between sometimes the question stems. Please remember, delusional is one single delusion. You're delusional about one thing. You're not delusional about you could be completely normal for the rest of your life, but there's one crazy thing that you believe. Schizophreniform and schizophrenia is mostly a timing thing. Schizophreniform is like schizophrenia light. Please remember the difference between bipolar disorder and the schizophrenic disorders is in bipolar disorder, your mood and actions are congruent. In schizophrenia, you will be either really depressed, but still like super active, or you will be super manic, but you will be at home not doing anything, right? Like your actions and your mood don't match in schizophrenia. For major depressive disorder, no SIGI caps. That being said, it's usually really obvious. You usually never get like four. You need five as criterion. They're never going to give you four. If the patient has like a whole bunch of stuff, specifically if it's affecting their life and it says like, oh, I'm not interested in doing things that I used to be, um, it'll generally be a major depressive disorder. All right. Onto the farm, or at least a big chunk of the farm. I hope by now we all know that it's calcium that triggers the release of all these vesicles of neurotransmitters in the presynapse, right? If you block reuptake, that's the same thing as increasing release, right? Because there's more in the synaptic junction now. Know the difference between the inotropic and the metabotropic receptors, right? They're mostly inotropic. They're almost all inotropic. Know the inhibitory versus excitatory transmitters, obviously. Yeah, that should be too much. GABA. GABA is for inhibition, right? There's a million types of pathology and drugs that work with the GABA. This is your benzos and your barbs. Definitely know that the difference between benzos and barbs is barbs increase the duration of opening. Benzos increase the frequency of opening. This is what is responsible for that ceiling effect where barbs, if I give you more and more barbs, eventually I'll stop you from breathing and you'll die. Whereas if I give you more and more benzos, that's really not going to happen, right? Acetylcholine, this is your acetylcholinesterase, right? This is really important because of myasthenia. You give acetylcholinesterase inhibitors to treat myasthenia, right? The whole muscarinic versus nicotinic versus adrenergic receptor thing is unbelievably stupidly high yield for step one. Not super duper important for you guys outside of the eyes, right? Where you're talking about like drug side effects. I shouldn't say it's not super duper important. This is definitely important. But I mean the distinction between like we're gonna give some very vague symptoms and ask if you would give them a pro-adrenergic, anti-adrenergic, anti-muscarinic, or pro-muscarinic drug. This is really important, so you should just learn it now. Is what I'm actually trying to say. Um, yeah, serotonin. You have a bunch of drugs, bunch of drugs. Definitely, we'll get to it later, but know the different ones that do these. And then dopamine. This is all your Parkinson's drugs and your mania. For strokes, it is most important that you know the contraindications for TPA. It is most important that you know the contraindications for TPA. I can't say that enough times. Usually, when they ask a question about this, they are asking, seeing if you know the contraindications for giving somebody TPA. Be familiar with dual platelet therapy. You put this, you start someone on this once they've had a stroke. Know the mechanism of action of aspirin if you don't already. Know that clopidogrel is the ADP inhibitor, right? So what this does is stops platelets from activating other platelets. Yeah, that's basically it. Oh, tranexamic acid is usually the one that they want for the reversal of alteplase. Definitely know this. Definitely know the empirical treatment for bacterial meningitis. In kids, you're giving ampicillin plus something else. And by kids, I mean babies. And everybody else, you're giving ceftriaxone. If you think it's S. pneumoniae, which is the most common, right? You're getting Advanc. So empirically, it's ceftriaxone and vancomycin because you're covering for everything, and then the vancomycin covers some of those common thing, right? Really obvious. 50 years old, you add ampicillin. It is really important that you know that you add ampicillin to cover for the cerebral people. They really like to ask about it. Past that, the rest of this should make sense. If it's susceptible to methicillin, you give a methicillin. If it's not susceptible to methicillin, you give vancomycin. Um, yeah, no, I mean this is really obvious, right? Like you give fluconazole. Meningitis is really bad, so we hit them with the big guns, right? Amphotericin, flucytosine, then fluconazole maintenance. That is really important. That progression is important to know. Um, Viral, obviously, you give an Ovir. CMV is ganciclovir is CMV specific. I definitely seen questions. Oh, granted, it was probably on a forum and probably not in this exam, but about the enzyme that I think the kinase that um, viruses have that activate the Ovir drugs. CMVs is different, and CMVs that's why you need ganciclovir. And then yep, that's basically it. As far as ADHD goes, just really know the difference between the stimulant drugs and the non-stimulant drugs. Um, Basically, all of them block norepinephrine and dopamine reuptake, but the difference is that your amphetamine drugs also increase the release of norepinephrine and dopamine. That's what makes this a stimulant. For your sedatives, again, overwhelmingly, the most important thing to know here is the difference between benzos and barbiturates. Can't say enough times. Benzos frequency, barbiturates duration. Um, you avoid benzos in elderly because of falls. Really, this is mostly what it is. Um, Buspirone, do not confuse it with bupropion. Right, buspirone is anti-anxiety. It's a serotonin agonist. Bupropion is Wellbutrin. It's a dopamine norepinephrine reuptake inhibitor. Please do not confuse those two. Please do not confuse those two. For your benzos, know the short acting versus medium acting versus long acting, and then know the ones for the potential for abuse. Short acting ones are Tom, temazepam, oxazepam, midazolam. Um, I remember this because somebody said something funny about some guy named Tom not lasting very long in bed. Internalize that. Drugs for abuse, adaprazolam, Adam, at Tom is how they like they're acting for the ones that can be abused. Should make perfect sense to you. It's just like opioids. The shorter acting they are, the more likely they are to be abused. And then know that diazepam is metabolized in the liver. Um, Yeah. So only the lot drugs are safe in liver disease, right? So that's your lorazepam, oxazepam, tenazepam, right? So generally, lorazepam is the safest one, right? Because it has a much lower likelihood of abuse than the other ones, right? The other two lot drugs, right? So know this, know this. This is a lot to know for what will at most be a question on your exam, but I can almost guarantee something that was just mentioned within the last 45 seconds will be a question on your exam. Remember that sleeping, it's all the EZ drugs, right? Zolpidem, Zeppelin, and S-zolpiclone. It has a Z in it. I'm pretty sure that this is the one that was on our test, and I was like, oh man, it should have a Z. Where's the Z? I'm looking for the Z, and then I was like, oh, it's in the middle of this one. Z drugs, Z drugs for sleep, Z drugs for sleep. Melatonin, um, Melatonin is just melatonin. This is the safest one for sleep, and then you have your orexin antagonist, suvorexin. Just be aware of the mechanism of action of these. That's all. Antidepressants. Um, when in doubt, give an SSRI. If they're asking about MAOIs or TCAs, it's usually about side effects. Please remember that venlafaxine, right? That treats your OPPs, right? So that treats your obsessive compulsive disorder, panic disorder, and PTSD. This is a norepinephrine and serotonin reuptake inhibitor, whereas SSRIs are just a serotonin, right? Selective serotonin reuptake inhibitors. They have OCD and PTSD here for SSRIs. Venlafaxine is your go-to. Number one side effect of SSRIs is erectile dysfunction. It's a sexual dysfunction, but it's usually erectile dysfunction. Please don't forget that. They ask about it all the time. TCAs have a ton of side effects, right? Tons of side effects. They ask about orthostatic hypotension an awful lot. MAO inhibitors. Remember the difference between MAO-A and MAO-B inhibitors, right? MAO-A inhibitors, which is what these actually are the antidepressants. MAO-B inhibitors are for dopamine and used in Parkinson's, right? And then all your atypicals. I feel like Wellbutrin's the one you'll be asked about the most. If you're asked about mirtazapine, you're going to be asked about the A2 antagonism effects. If you're asked about trazodone, don't forget trazobone. It causes priapism. If you see a question on this exam about an erection lasting more than 4 hours, it is not Viagra, it is trazodone. Oh, the other thing. Sexual dysfunction. Sexual dysfunction. SNRIs do not list sexual dysfunction as a side effect. You do not give someone, if someone has sexual dysfunction problems with an SSRI, you do not convert them to an SNRI. This is because these have much less sexual side effects, but it's not zero. So a lot of times they'll be looking for you to give Wellbutrin. Opioids. This isn't super duper relevant for this test specifically. Remember the thing that I said about the quicker acting ones and the more addictive ones. Please know that they work on the mostly like the mu receptors, right? Know that you this for sure 110%. Small pupils. If you see someone who has overdosed and it questions them, their pupils are small, pinpoint pupils. It is opioids. Treat with naloxone. Treat with naloxone. Treat with naloxone. Treat with naloxone. And then you can use naltrexone, right, which is an opioid agonist for either I'm so sorry, either opioid antagonism or for people with addictions to opioids or alcohol, you use naltrexone. And then the withdrawals. It'll be the worst flu we've ever had. You're not gonna get a whole lot of questions about this. Know that this is celecoxib is the selective COX-2 inhibitor. Know that it increases risk for MI for some reason. Aspirin, Rey syndrome. Don't give aspirin to kids who have viral infections. Toxicity. It eventually causes metabolic acidosis, which is this is a bit of a weird thing that you get really lost in the weeds on this. They're probably not going to ask you about this. Rey syndrome is a really big thing here. Rey syndrome and irreversible inhibition of COX-1 and 2. Those are your super big ones for aspirin on this exam. You know all about NSAIDs. Gabapentin. No gabapentin's mechanism of action. It's an anti. It says it's an anti-seizure medication here, but I'm pretty sure it's a pain med that is used as an anti-seizure medication, and not this other way around. Yeah, and then know that Tylenol, the reversal for Tylenol toxicity is N-acetylcysteine. Know that 100% for sure. Okay, this is super duper high yield. This is unbelievably high yield. NO, very safe. Low blood solubility. Why do we care about low blood solubility? I'll go over the whole thing. I know you guys are probably like, oh, please go over that. I hope he goes over that. Low blood solubility means it acts real quick. And because it acts real quick, it resolves itself real quick. And that is a very useful thing to have for inhaled anesthesia. Halothane is like the go-to for forever. Please no hepatitis. Halothane hepatitis. Also, malignant hyperthermia. Malignant hyperthermia and that neuromalignant syndrome, basically the same thing in terms of like question stems. Very similar side effects. You treat them the exact same. They're both caused by drugs. Malignant hyperthermia, halothane. Yeah. Oh, also increased intracranial pressure. Intracranial pressure. This has been relevant in a lot of questions. Yeah. I thought we were getting a lot of questions on this. We really didn't. Know what you need to know here is you need to know that these two are rapidly redistributed. And what that means is that they dissipate through the fat in your body, which means they kind of just like resolve quickly. Yeah. That's really it, honestly. That's really, 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 really it. You're not going to get too many questions in this. Know that this is what we use to put people to sleep, but we don't use it to keep them asleep. Local anesthesia, they're basically all sodium channel blockers. That's super important. Definitely know that. Also know that for local anesthesia, we'll add a vasoconstrictor. Why do we add a vasoconstrictor? A couple reasons. One, we don't want this going anywhere else in the body. Two, it increases its duration of action because it doesn't get dissipated. And then three is you need less of it, right? It makes sense. If it's all staying in the same area and it's not getting distributed and broken down, then you need less. It affects weaker nerves, right? So this should make sense to you. It's a sodium channel blocker. Myelinated nerves have less exposed sodium channels. Therefore, sodium channel blockers will be more effective against them. They will have smaller neurons have a higher surface area to diameter ratio. Sodium channels are on the surface, more effective. High firing, that just has to do with like refractory periods. This should also make sense. Basically smaller nerves that need to like do their thing a lot, like frequency wise, are more affected by local anesthesia. Know the differences with the ester and the amide links, right? Know that ester links have one I in the name. Know that amide links have two I's in the name. You will be just directly asked if something's an ester or an amide. You can just be directly asked if there's an ester or an amide linked one. Remember that these have more of a higher risk for ADRs. And then the other thing is bupivacain's cardiotoxic. Definitely remember that. This definitely know this. Definitely know this. Depolarizing versus non-depolarizing muscle relaxers, right? You'll see, and people will talk about that little like chart of like the I forget what it's called. Like there's like the little impulses, the different like phases. They don't really. I don't. You would think they would test on this, but you don't see a whole lot. What's super duper important is that succinylcholine is your depolarizing bucket, and pseudocholinesterase is what breaks this down, right? This is really important. Know that. Please know that. And then you have your malignant hyperthermia and your hyperkalemia. These are your two most important ADRs. A lot of times, like the question will literally be like, it'll tell the patient is in malignant hyperthermia, and it'll just ask you what they were given. Um, and then as for your non-depolarizing, neostigmine is the reversal agent they like to use. Sigemidex reverses literally all of them. However, like I said, neostigmine is the one they're going to ask. Know that the racronium and becronium are your steroidals, and then from there you can just deduce that everything else is a non-steroid. Okay, so this is really important. Definitely know this, guaranteed you'll have a question about it. This might be one of the arrows questions you get. It might be like a chart and it'll list these as numbers and it'll say which of these drugs is more potent or which of these drugs has a lower minimal alveolar concentration or whatever, right? Okay, really simply. High oil, more potent. Low gas, faster acting. Okay, why? Um, if it has a high lipid solubility, it crosses the blood-brain barrier more readily. That's how you should just think of it. If it crosses the blood-brain barrier more readily, then that means you need less of it inhaled to do what it wants to do, right? Increases potency. Increased potency, high potency, low minimal alveolar concentration. If it can cross the blood-brain barrier easily, we need less of it to do its job. Therefore, the minimum alveolar concentration, which is the smallest amount of the drug I can give somebody to have an effect. I think what it technically is the smallest amount of drug you can give half the population to have the intended effect, right? High oil gas, high potency, low MAC. Please know that. Blood gas coefficient. This is how readily it's going to dissolve in the blood. If the gas doesn't want to be in the blood, it's not going to stay there very well. If it doesn't stay there very well, it's going to escape very quickly. If it escapes very quickly, where's it going to go? Well, it's going to go into your brain, and it's also going to leave your body, right? So it acts fast, it resolves fast. Please know this. If anybody is still confused on this, I have absolutely no problem going over it 100 more times. Shoot me a message. This is a whole bunch of really important things. I'm not gonna lie. Okay, so know that obviously know the difference of this. You should be able to see a tube, or they should be able to describe a culture to you, and you should be able to tell right away if it's bacterial or if it's viral, which is aseptic meningitis, right? So with purulent, you're going to see less sugar, right? The reason you see less sugar is because the bacteria is eating it all, right? That should not be super difficult to understand. If you see neutrophils, it is because neutrophils are attacking bacteria. If you see lymphocytes, it is because lymphocytes are being recruited to fight off the viral infection. This should be really easy, really obvious to y'all. Why did I do it like this? I thought I gave you guys like just a actual breakdown of all these answers somewhere. Anyways, no, for sure, 100%, right? K1 capsular, right, that's E. coli. Gram-positive cocci, beta hemolytic, CAMP positive, this is your group A. Not group A, I'm sorry. This is your agalactate. This is strep agalactate. Cucurbitacilli, right? This is, it grows on, requires hematin, grows on chocolate agar. This is Hib, right? Hermophilus. Number one cause of meningitis past the neonatal age. I actually don't know what this is off the top of my head. I think it's Hib. It's either Hib or it's agalactate. Definitely, yeah. Know these. Be able to answer all these. This isn't my slide. I'll go back and find my side of this, and I will post it somewhere for you guys where I just have them just like straight laid out. But definitely know these. Definitely know these. These should be free points. Is this listed? No, these Cryptococcus neoformans. You're gonna get this picture usually. If you see this picture, you need to know it's Cryptococcus. This is something they can ask you. Latex agglutination, they like to ask about a bunch about the test for Cryptococcus. It comes from bird feces. You inhale the spores. Most common viral cause is enterovirus. What that means is the most common aseptic cause is enterovirus. Please do not forget that. If you see encephalitis in the temporal lobes, it is herpes. Saying smear is pretty commonly what they're going to actually ask you as a question of this. For these viruses, know the families. A lot of times they'll give you these in the stems, and you know what family they're from, right? Birds, risk, and elderly, right? This is oh my goodness, West Nile, right? This is your bunny. What is it, the bunny hantavirus, right? This is your equine equine virus. Know these, please know these, please know these. Tumors. Tumors are super duper duper duper, duper important. There's a bunch of different ways they can ask about these, but because there's like 4 different ways they can ask about these, they're always asking the same things. If you see a picture and the tumor is crossing the midline of the brain, it is almost always a glioblastoma. Almost always. Know that this is associated with an EGFR mutation. Know the term pseudopalisading. Know that it is associated with GFAP. And know both of these pictures. And you should get all glioblastoma questions correct. For oligodendrogliomas, fried egg cells is your big giveaway. A lot of times you'll get this picture. A lot of times they'll show you this picture. They'll explain something about oligodendroglioma, and then they will ask you what you're likely to see on a stain. Fried egg cells, right? Yeah, know this. Definitely for all of these, please know both the histo and the scan. It is so many free questions, free points for you guys. Meningiomas, right? Again, you'll see this. It'll be like a tumor. The continuum, the meninge. The big thing they like to talk about this is the laminated calcifications. Super high yield. Know that they come from the arachnoid cells, but very often they'll be looking for the laminated calcifications. Know this picture. Hemangioblastomas. This is usually associated with von Hippel-Lindau. They don't ask a whole lot of questions about these, if I'm being honest. However, sometimes if you see a question where they will be explaining like a vascularized, like a heavily vascularized tumor, this is 0 to. Usually, if they ask about the hemangioblastomas, it's not neuro, but I shouldn't say that. Any of the hemangiomas, neuro is not the one they're going to. Hemangioblastoma is obviously a neuro thing, but if you hear them talking about the thin walled capillaries, this will be like a very specific, just like it's a buzzword. They say this and they want you to know they're talking about hemangioblastoma. Ependymomas. This usually comes up in the case of obstructive hydrocephalus. So if you see a kid who has an obstructive hydrocephalus and they talk about a tumor, they could either ask you where it is, you know it's in the fourth ventricle. They could ask you what type of cells it originates from, so you know it's the ependymal cells. And then no pseudorosettes. Usually they won't give you this picture. They'll ask you to know like pseudorosette by term, like know the term pseudorosettes. Medulloblastomas is in cerebellum. Again, this can also compress the fourth ventricle, but overwhelmingly, if they're talking about a compression of the fourth ventricle, they're talking about ependymomas. This is definitely something that on the block exam, I feel like they really wanted to ask us. I'm not certain that this will be in the NBME question bank, if I'm just being really honest with you, but what will be there for sure is Homer Wright rosettes. Know for 100% sure, without any question, that medulloblastoma has Homer Wright rosettes and it synaptifies impossibly. Also know that this is the one that causes drop metastasis. I've definitely seen questions about that, 100%. I do have meningiomas on here twice. We just talked about these, right? Look for the calcifications. Schwannomas. Know that Antony A is like the wave where it's like really cellularly dense, and Antony B is where it's like not cellularly dense. I've definitely seen questions where they just explain like alternating banding pattern of dense versus sparse neural cells, and they want you to know based off of that it's a schwannoma because they're talking about these Antony like bundles. Know that it's S100 positive. Know that it comes from the Schwann cells. Obviously, please obviously know this comes from Schwann cells. Big thing, NF type 2, you get them bilaterally. causes the vestibular schwannomas, also called acoustic neuromas. Can present on cranial nerve 8. You get dizziness, right? Vestibular system's all thrown out of whack. But it can involve 7 also. 7 or 8, right? Usually. But point is, really important thing here is knowing that bilaterally, if you see this bilaterally, if they tell you they have bilateral schwannomas, or if you see an image with bilateral schwannomas, assume the person has NF2. Just assume the person has NF2. On to the kids. Pilocytic astrocytoma. This is the most common one, therefore you need to know it. GFAP positive, please know that. If you want to learn, if you have more room in your brain, remember the Rosenthal fibers. If you have a tumor in a kid and it is not obvious what type of tumor it is, assume it is a pilocytic astrocytoma. Medulloblastoma. This is your most common malignant. Again, this is your homocyte rosettes, synaptophysin positive. Right? Talked about that. Ependymoma, yep, same thing. Did I double this up or something? I guess so. Craniopharyngioma. This is your pituitary problem, right? Like it's the Rathke's pouch. This is super high. You'll definitely know this. Definitely know that the Rathke's pouch is where this comes from. I think most commonly that's what is actually asked. Is it'll talk about a calcified tumor, and it'll explain it's above the pituitary. And then either they'll just you need to know it's a craniopharyngioma, or you need to know it came from the remnants of Rathke's pouch. Please know that. And then pineal tumors. We talked about before Perinaut syndrome. You get the vertical gaze palsy because it pushes down like the vertical control centers, right? Top of midbrain. Usually, if they're asking you about a pineal gland tumor, it is because of the mass effect. So either it is obstructive hydrocephalus or the vertical gaze palsy. Know the difference between NF1 and NF2. NF2 is on chromosome 22. NF1 is on chromosome 17. Don't really know if you need to know that this is on chromosome 17. Definitely should know that this is on 22. Definitely see questions about this. NF type 2, man, overwhelmingly when they ask questions about this, the person will have bilateral vestibular schwannomas. If they don't, it's the other one, man. Cafe-au-lait spots, then the Lish nodules, which are like the spots in the iris. I've definitely seen questions where like they talk, it's very obvious the person has neurofibromatosis, and then they ask about the Lish nodules. Specifically that they're hamartomas, actually, now that I read this. Yeah, specifically knowing that they're at risk for hamartomas. Von Hippel-Lindau, also, you should definitely know. Specifically, you should know its association with hemangioblastomas. Very much know about its association with hemangioblastomas. All right, so that is exam 1. Now I'm gonna hop back in and I'm gonna run through exam 2, which should go quicker because we just did all this. Before I start this, does anybody have any questions? Or want me to hit something again, or feel like there's something that I missed that we missed the first time we went through this? Since these are NBME questions, they're a lot more straight. They're a lot less nitpicky. So it's a lot less important that you know like fringe facts. All right. Moving on forward. It's all with colorless diseases, right? I like the fact that he gives us these slides. Because you can just look and like, yeah, I do know all these things, right? The vestibular system. Measures the difference in the rate of firing between the neurons on either side. So if you increase the firing on the left side, that is the same thing. Your brain interprets that the same as knocking out the firing on the right side. So normally, you spin your head, right? I turn my head to the left. My brain recognizes that I'm turning my head to the left because of the direction the endolymph is flowing. And it corrects my eyes towards the center. If I have a problem that is making my brain think that my head is turning to the left, my eyes will drift to the right. Then my Visual processing centers will say, hey, wait a minute, my eyes aren't supposed to be moving. Why are you moving? Why is the world moving? And it will rapidly correct back towards the center, which is known as the saccade, which is what the nystagmus is named for. The slow component, which is the I'm trying to keep my head center, move towards the decreased rate of neuron firing. Right? If you remember the caloric testing, I had said that you put the cold water in one ear, right? Cold, right? It decreases, right? Cold generally like calms things down, right? Whereas hot will usually like excite something as far as like, I don't know, like enzyme kinetics or something, like just any biological process, right? And I like to use the like memory device of like, if I get splashed in cold water in the face, I'm kind of gonna like look to see like what happened, right? Decreased firing, slow component. Increased firing, back towards center. Slow component, decreased, right? So I turn my head to the left. My eyes are going to turn to the right. My right ear is going to decrease in firing. My left ear is going to increase in firing. Very important. As far as breaking down all the verticals, um, if you have hearing loss and it's fluctuating, if you have fluctuating hearing loss, if it's coming and going, if it's only in one ear, probably Meniere's disease. If you move around and get dizzy, it's benign positional vertigo. Know the Dix Hallpike maneuver, right? That's when you turn your head 45 degrees and lay it back, and you should get dizzy and get into nystagmus. Know the Epley maneuver. That's where you kind of like hold their head and like tilt it in every direction a bunch of times until all of the otolith settles back into place. The reason why this happens is because for BPPV, you have displacement of the otolith, which is the crystals suspended in the gel that's in the semicircular canals in the ear that are responsible for telling your head basically which orientation it's going, right? There's one in the three different axes. They're not quite X, Y, and Z. They're really kind of tilted like 35 degrees, but in relation to each other, they're roughly like they would be X, Y, and Z axes, right? Vestibular neuritis, this happens one time, then resolves, doesn't come back. This is neuro. Migraines can cause these. Usually, they're asking you to distinguish between usually they're asking you to, hey, this is BPPV and then know one of these, or they're asking you to distinguish between these two. Meniere's disease and vestibular neuritis is what they do. We just talked about this. Brainstem cerebellar stroke. Usually, dizziness is not the thing that you're answering that question based on because there's a million other symptoms. Okay, vestibular ocular reflex. We just talked about this, right? So, in an unconscious patient, you can do the Dahl's eyes test. If you are unconscious, your visual centers are not processing information, therefore, there will not be a nystagmus. You will not have the quick saccade back to middle. However, what you will still have is you will still have the vestibular ocular reflex as long as the brainstem is intact. So you tilt the head rapidly to the left. The eyes will try to still stay centered, and then they will slowly drift back towards center. If the brainstem is damaged, the eyes will remain fixed straight ahead, and no matter what you move the head around, the eyes will always be in the same position coming out of the head, right? This is the Dahl's eyes test. This is how you test the vestibular ocular reflex. You can then extrapolate that into caloric testing. We already talked about this, right? The slow movement towards the cold water, the fast movement, the saccade, is towards the hot water. So whichever side the hot water's in, that is the type of nystagmus that they'll have, right? So if you have hot water in the right ear, you'll have a rightward nystagmus. If you have cold water in the left ear, you'll have a rightward nystagmus, right? Cold, opposite, warm, same. So this in more or less words. So when you do this in an unconscious patient, they're unconscious, so they should not have a nystagmus. But the slow movement should still be intact. If you have a MLF lesion, medial longitudinal fasciculus lesion, one of the eyes will move and the other one won't. But what is it? What are you doing to me? I don't know why it's doing this. Well, I don't know why I went full screen. Sorry, you're just gonna have to suffer with this. If you have an MLF lesion, one of the eyes will move, but you won't have the nystagmus because you're not processing visually. So your brain won't notice. In unconscious patients, your brain won't notice that the eyes are not congruent with each other. The important thing here is to know that the vestibular system is responsible for the slow movement. Visual processing is responsible for the nystagmus. You can figure everything else out from there. INO, internuclear ophthalmoplegia. They love to ask questions about this, also known as MLF syndrome. The brain sends contralateral signals to the PPRF, telling it wants to move, wants to look, right? So if I want to look to the left, my right cortex is going to tell my left PPRF to abduct my left eye. The PPRF is going to tell the sixth nerve nucleus on the left to contract the lateral rectus muscle, turning the eye to the left. It is then at the same time going to send contralateral signals to the oculomotor nucleus, the third cranial nerve nucleus, to contract the medial rectus and adduct the right eye. If you lose the right MLF, this signal never makes it there, and the right eye does not move. It stays forward. The left eye will still move. Your brain will realize that your eyes are not facing the same direction, and it will try to correct this left eye with a rightward nystagmus. If you have an MLF lesion, the nystagmus is in the opposite eye, but in the same direction, like in the direction towards the same sides, right? So right MLF lesion, right nystagmus in the left eye. If you lose the abducens nucleus, obviously, the left eye is not going to move because there's nothing to tell the left eye to move. However, the right eye is also not going to move because the nucleus isn't telling the right eye to move. It's not telling the contralateral third nerve nucleus to move the right eye. If you have damage directly to the sixth cranial nerve, the left eye won't move. The right eye will still adduct, right? And then you'll get a weird other nystagmus, right? So it's very important, as opposed to trying to memorize all these things, that you understand how this system works. Very, very important. Signal from the brain crosses to the PPRF, tells the abducens nucleus, which causes the lateral rectus muscle to contract. At the same time, it tells the oculomotor nucleus, which causes the medial rectus muscle to contract. You get visual line. Yeah. This is a great diagram to test yourself on. Definitely know this. You will 100% have a question on this. While we're on this page, because of this, if you have a seizure is increased activity. This is the whole right way, wrong way lesion thing, which I don't really like the fact they refer to it as that, but it is what it is. If you have a seizure in your right frontal eye field, it is going to project signals down to your left PPRF, which is then going to tell your left abducens nucleus that the left eye needs to look left. Right brain, look to the left. Right brain tells your PPRF to the sixth nucleus to the third nucleus. Right eye looks to the left, right? So in the case of a seizure, you look away from the side that the seizure is localized on. I like to think of this as you look away from the flashing light. Why? Because flashing lights are like cause seizures, right? They're associated with seizures. You look away from the seizure. If this is stroked out, you look towards it, right? Like more or less, right? It's just the opposite, right? If you have no input, then these muscles are not being activated. So they, of course, the eyes are going to drift in the other direction, right? That should, but that's the whole right way wrong, I think. Just know it's usually asked in the context of a seizure. If you have a seizure, you look away from the seizure. This is the vertical gaze palsy, right? This is the sunset sign. So usually this is caused by a pineal tumor. So either it compresses on the vertical gaze center, right, which is in the rostral or like the top midbrain, right? Um, and it can also cause obstructive hydrocephalus. Really, just know that if you see them describing the sunset sign, you're usually talking about a pineal lung. Trochlear nerve palsy. This is the fourth cranial nerve, right, which is responsible for superior oblique. Um, this is the longest of like the cranial nerve. Well, this isn't the longest of the cranial nerves, but it has the most like susceptible to damage pathway. So it can be caused during stretching, so like whiplash or something. This is the one where they will have to like tilt their heads away from the lesion so that their other eye can match their messed up eye and gait, right? So if third nerve is palsy is down and out, this is up and in, right? Or up and out, up and out, up and out, up and out. I always say up and in because I want it to be opposite, but it's not. It's up and out. So you have to tilt your head away. So if you just do it right now, if you like move your eyes up towards the corner and then try to look straight, like you can kind of like mock in your own head how a person would be standing with this also. There's a refraction. It's important to know what kind of lens is going to correct which problem. Convex lens, also known as convergent lens, right? So convex, converge. You bring the image forward. So you use, in the case of hyperopia, the focal length is too long. The focal length of the eye is too long. So the image falls behind the retina. You need to bring it forward on the retina. You use a converging lens. Use a convex or a diverging lens to correct myopia, right? Why do you have myopia? Because the focal length is not long enough. The image is falling in the front. So this can happen. This happens if your eye gets bigger, right? You're growing. As you're growing as a kid, your eye can get bigger, and then all of a sudden the image is falling in front of the retina, right? As you get older, right? Like we talked about this. As you get older, the vitreous humor starts to kind of dehydrate. It shrinks, whatever you want to call it. Volume of the eye gets smaller. Image moves behind the eye, right? Now you need to bring it back forward with a converging lens. Know that an astigmatism is basically where the eye is just not uniform, so you'll have varying degrees of correction needed in different planes. They show that image with like the 12 thing, 12 different planes. Just generally know what an astigmatism is. There's one other thing that I definitely wanted to mention that I just thought of, and I don't remember what it was. Oh, oh, oh. As you get older, the muscles that pull the lens get weaker, and also the lens gets less malleable. This is gonna sound so stupid. I have seen questions before where they talk about this phenomenon, right? Um, which is why sometimes your vision can get better as you get older, because here, right, the focal point is in front of the retina, and then as you get older and this gets more lax, and like straightens up, the image starts to pull back, and it will fall back on the retina, and your prescription glasses can actually like your prescription can improve, your eyesight can improve. This is the same phenomenon that is responsible for causing wrinkling of your skin. I know that sounds really stupid, but this was certainly a question on something. I don't remember what it was, and people were furious about it. The lens changing as you get older is the same type of connective tissue degeneration that is responsible for the wrinkling of your skin. Glaucoma is an increase in intracranial pressure. Cupping of the optic nerve is like, this should be your absolute dead giveaway that it's glaucoma. Acute angle glaucoma is very rare compared to open angle glaucoma. However, it is the one that is dangerous. It is the one that is sudden. It is the one that we can cause. Therefore, it is the one that is tested a lot. The question stem will usually talk about how they're having a headache and redness of eye. A lot of times, it will basically talk about this and then ask what caused it, and the answer will be like, oh, well, we started them on a drug that basically caused dilation of the pupil, right? And then you end up with like this obstruction. Oh, I was really hoping you would beat the drugs. Oh, all right, we're gonna do this now. I think it's better to do this right? So when you treat glaucoma, there's a couple different things you can do. I like this page a lot. You can either, if the problem is increased drainage, you can decrease the drainage, right? If the problem is, if the problem is decreased drainage, you can increase the drainage. If the problem is increased production, you can decrease the production, right? So it's really important to know that prostaglandins, they increase the UV scleral outflow, right? The UV scleral outflow, which is just like, it's honestly like everything, right? Whereas the muscarinic agonists, they specifically increase the trabecular outflow, which is like in this one specific spot, which is the kind of part that gets closed off in post-cyclical glaucoma, right? I know the eyelash thing, I know it's dumb, but I've definitely seen it in questions. And then with the decreased production, alpha-2 agonists, beta blockers, caution and asthma, right? And then carbonic anhydrase, this is the only time you will probably ever put in an exam that you give someone acetazolamide, because usually they're asking about ADRs. Know that in acute angle glaucoma, you have to do surgery basically. And you're just giving these drugs as like a stopgap until you can get them into surgery, and you hit them with everything. That's it. That's what's important to know. So back to this, macular degeneration. There's the two types. Know the difference between wet and dry. Wet, you have neovascularization. Wet generally means there's cardiac involvement, right? You think about like wet beriberi versus dry beriberi, right? It's the same thing, wet macular degeneration versus dry macular degeneration. The things that you see accumulating are drusen deposits. 1000%. This is a huge buzzword. It'll like, sometimes this will be the actual answer to the question. Know that you lose the central vision, right? Because it's like accumulating on the retina. For wet macular degeneration, know that we use VEGF inhibitors, vascular endothelial growth factor. The problem is we're having neovascularization, so to fix it, we give VEGF inhibitors. Also, quick aside, in neonates who are born with AR premature, I think it's like 28 weeks or whatever, is like the cutoff. And especially when they're at high risk for ARDS, right? So a neonate with ARDS is put on 100% oxygen. When they're put on oxygen, your body now recognizes that you have oxygen-rich blood more so than you normally would. Therefore, your body decreases production of endothelial growth factors. So you lose VEGF, which means you lose vascularization of the eye, which means that neonates who are born premature and have ARDS and are treated for ARDS have a risk for a lack of retinal development. Retinal detachment, this is when the vitreous and the kind of pulls away from the retina, right? You get separation of the retina and the retinal pigment epithelium. So basically the layer that like absorbs light and like the nerve layer. This usually happens because as you get older, this vitreous becomes kind of dehydrated, right? And you'll see sudden floaters and flashes of light. This is painless, that's super high yield that's painless, super high yield that you see sudden floaters and flashes of light. This does not mean that if you see floaters, which I have my entire life, that you have a retinal detachment. However, if you see these suddenly, it does. Very common in the elderly. Yeah, it's painless. Most of the eye things are painless. The only things in the eye that like are painful, like really painful, is uveitis and acute angle glaucoma. If they're talking about a lot of pain, it's either uveitis or acute angle glaucoma, or it's a cluster headache in a 20 to 30-year-old dude. Ganglion cells, I know I super beat this to death when we talked about it. Please know this. I'm sure you had 2 or 3 questions about this on your last exam. It's just gonna be in the final, I guarantee it. M is for movement. P is for perception. M, magno, means large. P, parvo, literally means small. I know I messed this up, and for the 3rd time, I'm giving you guys this slide, and I still haven't fixed it. This is all backwards. All backwards. So the M cells are peripheral. Why are they peripheral? Because we need to detect motion in our peripheral vision. The sides of our vision are for movement. The middle of our vision is for processing. We have very wide. The ganglion cells in the peripheral retina cast a wide net so that they can cover a larger area, right? Whereas the little ones, we need like high pixel density, right? You think of it like a computer screen. So because of that, because these are used to detect motion and these are used to figure things out, right? And like resolving power, it should make sense that these transmit the signal fast and these transmit the signal slow. These startle you when you think you saw a spider. These are the ones that you use when you realize it's just a piece of lint, right? Please know this. Please know this. Visual pathway lesions, I highly recommend you're able to just draw this out. If you can draw this out, you can answer any question on it. Generally, look at this and realize that the left side of the vision projects to the right side of the eye. The right side of the vision projects to the left side of the eye. It is both backwards and upside down is how it projects on the retina. Our brain needs to sort this back out, right? So what happens is the left side of our field of vision hits the right side of our eyes, and then it's going to go to the same part of our brain, right? Because we process the left side of our vision with one part of our brain, the right side of our vision with the other part of our brain, right? So temporally does not cross. Nasally, and I'm talking about, oh my goodness. All right, I don't want to keep using this. Restart. The temporal field of view projects to the nasal retina. This crosses immediately in the optic chiasm. The nasal field of view projects to the temporal retina. This does not cross. So what does this mean? What this means is each side, right? Because like you have one crossing and one not. Each side of your field of view, right versus left, travels together after the optic chiasm. So if you lose half of a field of view, right? If you lose half of a field of view, you have to have some damage between the optic chiasm and the lateral geniculate nucleus, so your optic tract is damaged. If you have the same like region, so either like temporal or nasal, that's missing in both eyes, then you know it has to be at the optic chiasm because it's the only place that they cross, right? Specifically, it's usually going to be binasal hemianopia. Why? Why binasal hemianopia? Well, because this is crossing and the pituitary is right there, and it's really easy since get pushed on. If you lose half of your if you lose the other half of your field of view, it's going to be an internal carotid aneurysm, right? Pressing on the nerve on the side of the optic chiasm. Generally, this is not bilateral. The reason this is generally not bilateral is because it would be really hard to have an aneurysm in both of your internal carotid arteries. So usually you don't get binasal hemianopia. This is wrong, right? He has this color wrong, doesn't he? Oh, no, he doesn't. Yeah. So binasal hemianopia, right, would be like if you have bilateral, this right here would be like if you have bilateral internal carotid artery aneurysms. Very rare. Usually it'll just be unilateral hemianopia. Bitemporal optic chiasm damage, right? Very important, very important. And then here, right after the lateral geniculate nucleus, now you've gotten to the point where you've already you've basically cut the vision in half twice, right? So now you are in quadrants, right? So if you're talking about a loss of a quadrant, it has to be after the lateral geniculate nucleus. If you're talking about loss of half of a field of view, it has to be before the lateral geniculate nucleus. And then if you have macular sparing, it's in the back. It's a posterior cerebral artery deficit. Don't forget Lupin-Myers, dick radiations. I don't know if that has another name, but with your Lupin-Myers, you have your the whole what pie in the sky thing, right? Goes down, makes sense. It's backwards. The top left corner of your vision, just like everything else in the brain is backwards, the top left corner of your vision is damage to the bottom right portion of your visual tract. Definitely know this. Definitely know this. It is 1,000 times easier if you can just draw it out. It is even if you don't like 100% remember this, if you can just do this, you're already in a great spot. If you can just do that, all right. All right, I know I just drew the whole thing out, but if you can just do this part, just the top, even if it's just this, it's really annoying. Even if it's just if you can just do this, you're in a good spot. Talk about these. The thalamic nuclei. See, this is a flashcard topic. I don't want to waste your guys' time with flashcard topics. But just generally know these four. Know the difference between the VPL and the VPM, right? L for limbs, M for mouth, right? This is your body, this is your head. And then medial lateral geniculate nucleus, it's backwards like everything. Optic tract, your eyes are more medial to your ears, therefore in the brain they're more lateral to your ears, right? Just know this, please know this. Know all of the motor nuclei together, the ventrolateral, ventral anterior, ventral intermedial. They're not going to ask you to distinguish between the VL and the VA, but they will ask you to distinguish between these and these. The hypothalamus, this is the important ones. These are the super important ones. Definitely. Why is it doing this? It's doing all kinds of weird things. Definitely know these. Definitely know these. Mammillary body is super important, right? As far as reflexes go, you have to know that the spindle fibers are responsible for stretch, and the Golgi tendons are responsible for like too much weight, right? You know that these are in parallel, these are in series. You should know that these are monosynaptic and these are disynaptic, and that these are polysynaptic, right? But you can figure that out if you just think for a second about what they do, right? The stretch reflex, the only thing that this does is tell me to apply more force as more weight is added. Monosynaptic. The Golgi tendon, this tells me to extend my arm, so I have to relax my bicep and contract my tricep, right? Disynaptic. Polysynaptic, I'm withdrawing one leg and extending the other to maintain my balance. So that's four, right? This is one nerve, two nerves, four nerves, right? Should make perfect sense. Upper lower motor neuron injury. Man, I sure hope you can do these by now. Remember, any upper motor neuron injury is literally anything. If you're talking about the, like limbs, right? It's anything before the anterior spinal horn. Anything before the anterior horn. Babinski sign is like the dead giveaway most questions. Upper motor neuron injuries, overactive muscles. Lower motor neuron injuries, underactive muscles, right? The difference between like spasms and fasciculations is in a spasm, the whole muscle is contracting, whereas fasciculations, it'll be like teeny individual fibers within the muscle itself, but the muscle is not contracting. Very important. The tongue deviates toward the size of the cranial nerve lesion. However, if you have damage to the corticobulbar tract, which is everything before cranial nerve 12th nucleus, then it will be away from it, right? That should make sense because this is the upper motor neuron, which crosses, this is the lower motor neuron. which has already crossed. I had mentioned before that sometimes they'll give you like a really obscure description of like the tongue or a picture of it. And you have to basically determine whether the tongue is fasciculating or whether it is spasming. And I don't know if you guys are going to know what I'm talking about, but there's like some people can do that thing where they like, fold their tongue a bunch of times, like in and on itself, and it's like really wavy. It looks like I don't know, like a cupcake holder, I guess, like the little like ruffly things. If you see a picture like that, it's spastic, and it's probably an upper motor neuron lesion. Just something to keep in mind, because if you see the tongue deviating to one side and it looks spastic, or they talk about spasticity specifically, it is an upper motor neuron injury. They want you to know that it is on the contralateral side. Well, palsy, please know this. The top half of your face is innervated by both sides of your brain. So if you have an injury, or not injury, but if your whole face is paralyzed, you know it's seventh nerve palsy. So the damage is just to the seventh nerve, or the seventh nerve is agitated. If only the bottom corner of your face is paralyzed and not the top, then it means you have a problem in the brain itself, in the cortex, which is bad. Strokes. Know how to localize strokes. Know what supplies them each. I'm sure there's done enough questions by you've realized that if there's problems with the legs, it's the ACA. If there's aphasia or there's problems with the arms or the face, it's the MCA. It's not super hard. If it's only motor, it's the internal capsule. And then if they're talking about weird cranial nerve things, always localize brainstem injuries based off of the cranial nerves. You can basically answer every single one of those brainstem questions based off of only the cranial nerve signs. Watershed strokes, we talked about this. We already talked about this. No, this little homunculus, the center of the vermis is the center of the body. If you lose in the middle of the vermis, you get truncal ataxia. If it's on the sides, you get limb ataxia. Know all of these terms. Dysdiadochokinesia is the hand flipping thing. Know the difference between intentional tremors and resting tremors. Resting tremors specifically are you're just not doing anything. Intentional tremors like you go to reach for a cup or like hold a cup and you start to tremor, right? Know these. Just know all these. Know all these terms. These are just buzzwords. Friedreich's ataxia, GAA. For all these, please know the gene and know the repeat. With Friedreich's ataxia, another big one is the hypertrophic cardiomyopathy. It's what usually kills them, so like it's something to like really keep track attention to. But please, GAA for taxin. Definitely know those. And also I think I said this before, but this iron metabolism causing oxidative stress in the mitochondria. I've gotten a question wrong on this before because I didn't know that. Limbic system, they don't get super into detail on this. If they're talking about this, they want you to like generally know that like amygdala for fear or anxiety. They want you to know what Kluver-Bucy syndrome is. They want specifically the big buzzword for this is the hyperorality. And then, like I said, the mammillary bodies. This is really big in Wernicke-Korsakoff syndrome. If you have confabulations, which is where you're making stuff up, and you don't know that you're making stuff up, it is Wernicke-Korsakoff syndrome. That is what adds the Korsakoffs to confabulations. This is caused by a thiamine D1 deficiency in alcoholics, or it can just be caused by general damage or stroke to the mammillary bodies. Generally, very generally know this. Know that if you damage the prefrontal cortex, that's when you get like the complete shift of personality, which you should know. Then if you get like frontal temporal lobe dementia or something like that, right? It's in the same area, and so you can get the personality changes. Wernicke-Hoffman, this is floppy baby disease. Know the gene, survival motor neuron gene. Survival motor neuron gene. If you don't have the gene that makes your motor neuron survive, they die. It's a lower motor neuron injury, hypotonia. Polio, a lot of times they'll ask about the vaccines. I think I've said this before. It's usually the limbs that are paralyzed. It's flaccid paralysis. Know that it's flaccid paralysis. Know the stuff about the vaccines. Know that it's fecal oral, and know that it likes to live in the ventral horn. ALS, you will get mixed upper and lower motor neuron signs. That is almost always how you know that it's ALS. Niemann-Pick, most of the time they're asking you about this. They're asking you to distinguish it between Tay-Sachs disease. Look for the hepatomegaly. If you don't have hepatosplenomegaly, it is Tay-Sachs disease. It is not Niemann-Pick. Trimed Racula is like that giveaway, but like I said, it's in both of them. Know the NPC 1 and NPC 2 genes. If they tell you that the patient has Niemann-Pick and they give you a multiple choice question of genes and you can't figure out that NPC 1 and NPC 2 are Niemann-Pick type C, I'm really sorry. I don't. Most of the genes from this are like that. Please, please, please pick the obvious choice. As far as dementias go, really the big ones here is knowing that APO2 increase or decreases the risk and APO4 increases the risk. APP is your amyloid precursor protein, right? This is presenil 1 and 2. It's on chromosome 21. People with Down syndrome are predisposed to Alzheimer's. They usually get it in their 40s. Early, you get memory loss. Late term, you get personality changes. That's when you basically don't recognize your family anymore. Definitely know the histo for this stuff. Know the histo and know the raw slices for these things. Vascular dementia, you'll see a gradual decline over time. They'll give some indication to some of the patient has a lot of like cerebrovascular incidents. Frontotemporal lobe dementia, this is when you get the very, very, very rapid personality changes. You get these PIC bodies. It's important to know that the PIC bodies are tau protein or TDP43. This is a very specific type of FTL. And then you get the knife edge showering. Lewy body dementia, this is your accumulation of alpha-synuclein. These are your Lewy bodies. The association with REM sleep disorder. If somebody like is in like early 40s or late 40s, early 50s, and they just all of a sudden have Parkinson's out of nowhere, and they're also having like hallucinating, and they have like the very late stage dementia like type syndromes, it's Lewy body dementia. Alpha-synuclein is super important in high yield. NPH, we talked about this. Please don't miss that. Creutzfeldt-Jakob disease. Basically, if somebody's like 40 or 50 and they're just losing it out of nowhere, it's one of these two. It's either Lewy body dementia or prion disease. With prion disease, they're usually going to give you either sharp waves on EEG, increased 1433 protein in CSF, or spongiform degeneration of cortex. Know this picture. I've seen this exact picture or one that was so similar to it, I couldn't tell you the difference on multiple exams and one of the forms. And then HIV dementia. Generally, they're going to give you somebody who CD4 counts in the absolute gutter. You're going to think maybe it's cryptococcus, and then just something in the stem seems off. Look for this picture. Look for multinucleated giant cells. Bad HIV in and of itself causes dementia. Here's all the genes. Basal ganglia. No, Huntington's disease is in the caudate mostly. Right, your hemibilismus. This is pathognomonic for the subthalamic nuclei. If you see subthalamic nuclei damage, or if you see hemibilismus, you don't put like they go together every time, 10 out of 10 times. Parkinson's is degeneration of the dopaminergic neurons in the substantia nigra. Please do not forget that. It looks literally lighter. It will literally, yep, right here. Right, it looks lighter. Go for the dopaminergic pathways, GABA and glutamate are your neurotransmitters. GABA is inhibitory, glutamate is excitatory, obviously. Know that dopamine 1 is your direct pathway. This facilitates movement. Dopamine 2 is your indirect pathway. This inhibits movement. How does it do this? By inhibiting and activating the globus pallidus interna. The GPI is inhibitory for movement. Therefore, if you dopamine 1 receptors inhibit the GPI, which increases movement, dopamine 2 receptors activate the GPI, which decreases movement. Parkinson's disease, you'll have your shuffling gait, mast-like fate, dead giveaways, cogwheel and lead pipe rigidity, dead giveaways. Sometimes the last is just answers. Alpha-synuclein deposits, right? Lewy bodies. Just because you have Lewy bodies does not mean you have Lewy body dementia. You will see Lewy bodies in regular Parkinson's patients. Huntington's disease, mostly in the caudate, displays anticipation, wildly high yield. It's the CAG gene. You remember this because the caudate loses acetylcholine and GABA. It also has increased dopamine, but mostly you lose acetylcholine and GABA. That's why they talk about it. Symptoms manifest between 30 and 50. However, because of anticipation, generally in the stem, the patient will have, it'll be like a boy who his uncle had Parkinson's, or not Parkinson's, Huntington's in like his early 40s, but it doesn't like quite say that, like you have to infer. And then this kid had it younger, like it onset younger, right? Because anticipation is a big deal with Huntington's disease. You have Wilson's disease. Please know that it's ATP7B gene. This is defectiveness in copper, right? You have your Kaiser-Fisher rings. You detect that with a slit lamp exam. You can also do seroplasmin levels, which will be low. Urine copper will be high. Serum copper will be high. You use penicillamine to treat it. It is a chelating agent that pulls copper out of the blood. These questions should always be free. Hemibilismus, subthalamic nuclei, hemibilismus, subthalamic nuclei, hemibilismus, subthalamic nuclei. Parkinson's drugs. This is just the same one from earlier, but I added these genes. I think the only one here I didn't talk about is SOD1 is ALS. Parkinson's disease, we just talked about this. Really, really big one just to hit on again. Remember, MAO-B inhibitors treat for Parkinson's. MAO-A inhibitors treat for depression. This is your levodopa carbidopa. Levodopa gets converted to dopamine. Carbidopa prevents levodopa from being converted to dopamine in your body. Levodopa crosses the blood-brain barrier. Carbidopa does not. Levodopa alleviates Parkinson's symptoms. Carbidopa reduces side effects. And here's basically exactly what I just said. As far as the patients go, it's almost always BRCAs or Wernicke's are talking about. This is your MCA strokes. BRCA, broken speech. Wernicke's word salad. If they're talking about repetition, remember that in conduction aphasia, they can't repeat words you said. They can kind of sort of say something similar to what you said, but they literally cannot repeat the phrase that you gave to them. Very rarely do they ask about transcortical or global aphasia. A lot of times, the only time I've ever seen them ask about conductive aphasia, they described conductive aphasia and they asked where the damage was. And Broca's area was an answer. Wernicke's area was an answer. The like motor cortex of the like mouth muscles was like an answer, something weird like that. And then the arcuate fasciculus was the correct answer, right? Which is what's responsible for conductive aphasia. Frontal lobe disorders. If it's on the right side, it's spatial neglect. If it's on the left side, you forget how to do something, whether it's reading or writing or doing math. Yeah. If it's on your dominant lobe, which is the left side, is usually an aphasia, or you get this Gerstmann syndrome. If it's on the other side, you get spatial neglect. Headaches. Know these. Just know based off of the description. Know which one is which. Do not forget that you treat cluster headaches with 100% oxygen. You know, use triptans. Usually they're talking about abortive therapies when they ask you questions. They're not usually talking about preventive therapies. For migraines, the CGRP inhibitors, I've seen a lot of questions about these. No topamate, no valproate, and no the CGRP inhibitors. And then the pseudotumor cerebri, this is going to be an overweight female patient in her 30s with papilledema, maybe some vision loss, and headaches. Personality disorders, they never ask you to cluster them. It's usually pretty obvious what they are. The big ones that people get mixed up is antisocial. You are being actively destructive to your environment and the people around you. It is not that you don't like people. Then schizoid, you are what people colloquially refer to as antisocial. You don't have friends. You have no interest in making friends. You don't see why people would want more people in their lives. You're perfectly content keeping to yourself in your home. Avoidant, you are avoiding making friends despite desperately wanting them because you're terrified of rejection. Schizotypal, this is a really eccentric person. Some old lady who, it doesn't matter to be an old lady, but like, I don't know, man, like someone who believes in the healing power of crystals and astrology and all that kind of stuff, right? Schizotypal. And then OCPD is what people usually think about when they're saying like, oh, I'm so OCD about this, right? You're really rigid about things. You're really particular about things, but like it's not an obsessive compulsive disorder. Eating disorder is the big thing here. Anorexia, you have to be lower than 18.5 BMI for the purposes of the exams. There is a type of anorexia where that is not it's like a subcategory where you can be overweight, but for the purpose of exams, you have to be underweight. You also almost always have body dysmorphia. Treat with olanzapine. For all of these, avoid stimulants, avoid Wellbutrin. Bulimia, you have to have binge eating with compensation. Binge eating with compensation. If it doesn't, they're not, you have to have binge eating and compensation, whether it is vomiting or forcing yourself to go to the gym or looking at yourself and chastising yourself in the mirror. You have to have inappropriate binge eating with some type of inappropriate compensation after for having eaten. You treat this with SRIs like everything else. And then binge eating disorders is bulimia without any type of compensation. Then you treat with SSRIs. For your mood disorders, you know there's unipolar and bipolar mood disorders, right? The big thing to be careful of is if you're diagnosing someone with depression, you need to make sure they're not bipolar, because if you treat the depressive symptoms and they're bipolar, you will push them into mania. The other thing is the distinction between hypomania and mania. In order to be bipolar 1, you have to have full mania. We're talking about, talking to God, thinking you're God. Jesus is your homie. Whereas with bipolar 2, maybe you're just being like really productive and hyperactive. The other thing to keep a note is technically you do not need the depressive episode to diagnose with bipolar 1. Manic episodes alone are enough to diagnose with bipolar 1. I've only ever seen one question like that, but it is technically correct. The way that Dr. Trubodorov said this that really stuck with me is if somebody is bipolar 1, the police brought them to the hospital. And then schizoaffective is basically sort of, it's like psychosis with mood episodes. But the big key to itself is you must have psychosis when they're also at their baseline. Also, please don't forget bipolar disorder, your mood and your actions are congruent, whereas with the schizotype disorders, your mood and your actions do not match. Please know the timings. Timing's really important. Be able to distinguish between a brief psychotic episode and a delusion. Again, a delusion is just one thing. For substance abuse, these are the super important ones. The rest you can just figure out by knowing what drugs, like the street value of drugs, really, or like the pop culture effect of drugs. Please know pupil dilations, it's a stimulant or a hallucinogen. Pupil constrictions, it's an opioid. If there's a nystagmus, it's PCP. The stem for a nystagmus overdose and a cocaine not overdose, but like somebody who comes in high on PCP versus someone who comes in on nystagmus will be identical. The question stem for somebody who comes into the hospital after doing a bunch of cocaine versus a bunch of PCP will be pretty much identical, with the exception of the presence of a nystagmus. The presence of a nystagmus is what lets you feel comfortable knowing that they're high on PCP. Know all the mechanisms of actions for all of these. If you know what the drug does, you should know what the withdrawal is. I put this in here because he put it on his slides, and I doubt he'll ask you to know anything that's not on here. Know the stages of change. Usually it's between contemplation and preparation that they want you to distinguish. For contemplation, you know there's a change, but you're not doing anything about it. You might even know that you need to do something about it, but you're not gonna. Preparation, you are 100% planning on making a change. Action, you have already started making the change. Knowing you need to lose weight and getting a membership is preparation. Physically going to the gym is action. Antipsychotics, the biggest deal here is knowing that the first generations are D2 antagonists and the second generations are mostly serotonin antagonists. This is for positive symptoms, so like hallucinations and stuff, whereas this is for negative symptoms. They do also block, the second generations also block dopamine, but that's not like their main mechanism of action. And then of course, if you're blocking dopamine receptors, then you have a chance of pushing them into Parkinsonian symptoms. Yeah, I'll talk about this when we get on the other side. So you're blocking dopamine. Dopamine and prolactin are inversely proportional to each other. So of course, if you're blocking dopamine, you have a chance of increasing prolactin. You get hyperprolactinemia, right, which can cause amenorrhea, galactorrhea. Also, you can get extrapyramidal side effects, right? We were just talking about this. if you block dopamine, then you have more dopamine, right? Or I'm sorry, if you block dopamine, you have less dopamine, and you get Parkinson's, right? So how do we treat this? You can either treat the side effects directly. Well, that's really it. You treat the side effects directly, right? You give central anticholinergics because, as we talked about before, Parkinsonian symptoms is not just about not having enough dopamine. It's about having a imbalance between too much acetylcholine and not enough dopamine. So it's more like a balance, kind of like the vestibular system, right? Where like it's not enough just to have one suppressed; it needs to be like in proportion to the other one. So, how do we fix someone not having enough dopamine? Well, you can either give them more dopamine, which would we're treating the mania, right? Or you can decrease the amount of acetylcholine. Neuroleptic malignant syndrome, right? Basically the same thing as malignant hyperthermia. Um, you treat both with dantrolene. Know this. You will have a question about one of them. The answer will be dantrolene. Okay. For bipolar disorder drugs, lithium and valproic acid. Know that lithium causes the Epstein anomaly. Know that valproic causes neural tube defects. Epstein anomaly is the atrialization of the right ventricle. Neural tube defects, this will usually be like you see neural tube defect and you think spinal bifida, but it's usually encephaly that they're talking about valproate. Also, that's hepatotoxic. And then please do not forget the diabetes insipidus induced by lithium toxicity. If someone has DI and you give them a lithium-induced DI and you give them a thiazide, you'll make it significantly worse. Therefore, it should stand to reason that giving ACE inhibitors and thiazides can lead to lithium toxicity. If you get the question talking about this, you treat it with amelioride. Anti-epileptic drugs, they're basically all sodium channel blockers except for ethosuximide. Ethosuximide is given for absence seizures. It blocks T-type calcium 2 channels. 1000% you need to know this. You also need to know absence seizures, but please know that it blocks T-type calcium channel. Beyond that, know that valproic acid is a CYP inhibitor and that phenytoin and carbamazepine are CYP inducers. Also know that lamotrigine and carbamazepine can cause SJS. It is more associated with carbamazepine. Also know that you use carbamazepine to treat trigeminal neuralgia. They like to ask that for some reason. Then prosthetic epilepticus. So this is if you've had a seizure for more than 5 minutes and it won't stop. You give IZ benzos or barbs. They usually give benzos if they can. Why? Because benzos have the ceiling effect. When you're giving IV benzos and barbs, you have a higher risk for respiratory suppression than when you're giving IV barbs. So it's better to give IV benzos. Again, frequency, whereas barbs are duration. As far as sleep goes, the really big important thing to know is that all the disorders really take place in stage 3 of sleep. It's kind of debated whether or not stage 4 is even a real thing, but stage 3 is where you get like your bruxism, so grinding your jaw, sleepwalking, your night terrors. You do not remember things that happen in stage 3 of sleep. You do remember things that happen in REM. As you get older, your REM sleep latency goes up. With narcolepsy, it goes down. So what that means is with narcolepsy, you're inappropriately falling into REM sleep sometimes during the day, right? This is really important. Knowing this specific is really important. This is due to a deficiency in orexin. Modafinil is a non-amphetamine CNS stimulant that is used to treat this. I would know this. I would know both of these things. Know what happens when we age. And know that, again, nightmares, you remember, they happen during REM sleep. Night terrors, you do not remember, they happen during stage 3. How do you know it's stage 3? Delta waves. Delta waves and stage 3 are really important, knowing that those two go together. REM behavior disorder, this will happen sometimes in dementia patients, where basically they lose descending inhibition from their pons, so they start to physically act out their dreams. It happens mostly in males. No spike and wave or absence seizures. If you see spike and wave on an EEG, what are we going to give them? Ethosuximide. How does it work? T-type calcium channels. And then epilepsy in a nutshell, this is grand mal seizures is what you like your stereotypical seizure, right? This is your tonic-clonic seizures. And then you have the petit mal, which is your absence seizures, treated as insexamide, spike movement EKGs. Temporal lobe epilepsy, usually this is you will have some type of gustatory or olfactory hallucination. So you'll either smell or taste a really like burning rubber right before you have the seizure. Juvenile myoclonic seizures, this usually happens if you see them talking about someone having seizures when they wake up in the morning. It's usually this really high correlation with waking up in the morning. This is your spikes and your slow waves on the EEG, right? Not to be confused with the spike and wave, the absence seizures. You'll see spikes and slow waves. We talked about static epilepticus. This is more than 5 minutes. Give IV benzos or bars, preferably benzos. And then febrile seizures. Do not treat febrile seizures. Treat the fever. The seizure will go away. This is normal. I think like 10% of infants have febrile seizures, which something that seems way higher than it should be. All right, and that's actually it. I'm sorry, I know I sped through the back half of this, but we literally just did this last week. You guys are fresh on the exam for this. I trust that you know a lot of this stuff. That's all I got for today. Does anybody have any questions at all about anything? It doesn't even have to, at this point, it doesn't even have to be about BAB. It can be about CLR, honestly. Since it's like right around the corner for you guys. Of course. Of course. I hope it was helpful. I hope you guys, I hope I made BAB easier for y'all. I know that some of it can seem more confusing than it really is. I'll post the report, put the recording on the YouTube channel with all the other ones. Yeah, I got nothing. Thank you guys. Thanks for being patient. Yeah. As always, I'm available on WhatsApp. Just shoot me a message. I think you guys' test is when Tuesday. If you want to have like a WhatsApp call and have me run through something with you, I don't mind doing that at all. Just shoot me a message. Other than that, good luck. And enjoy your break before CLR. Don't try to like cram like the week before your fake mini comp thing. It's not worth it. Just please take this time to recharge and start CLR fresh after Tuesday.